Happy evening to all. I take this opportunity to welcome you all on behalf of Hetero Healthcare. My name is Rajamanikam, working as a Senior Sales Manager of Hetero Healthcare, Helian CNS Division for South. First of all, I am thanking you all for joining us today to discuss on the topic Cholinergic Pharmacological Management, latest update in Alzheimer's. As you know about Hetero Healthcare, we are the largest R&D wings having 360-degree solution providing facility, more than 25 years of excellence in multiple therapies, currently present in more than 126 plus countries worldwide, more than 300 products across various therapeutic categories such as HIV, AIDS, oncology, cardiovascular, neurology, distinction of bringing 4 biosimilar products to the market, 36 plus state-of-art manufacturing facilities, pioneering in the quality and innovation. Today, we have with us as speaker Dr. G. Prasad Rao, Director, Asha Hospital, Hyderabad. His academic qualifications are DPM in Nimans, MD Psychiatry in PGAM year, Chandigarh. Dr. Prasad Rao sir is a university rank holder throughout his academics during MBBS, during MD, during DPM, and best outgoing student in every institution. He was a gold medalist in MBBS and a bronze medalist in his PG Psychiatry. He received more than 20 national awards and 5 international awards for his research activities in psychiatry. He is a Lifetime Achiever Award recipient of SARC Psychiatric Association as the Best Lifetime Achiever in Psychiatric Services. Last 40 years, after completing his PG, Dr. Prasad Rao worked in various renowned institutions like Nimans, PGI Chandigarh, currently working as a director of Asha Hospitals, Hyderabad, and heading the schizophrenia and Alzheimer's wing. He, as an academician, worked on various research work and published papers, national and international journals. He was principal investigator in more than 12 research studies, multicentric drug trials in India. His contributions are numerous to IPS, SARC, and World Psychiatric Forums, and especially private psychiatry as a branch established by him in India. He is a founder of Indian Private Psychiatric Association. He was the president of Indian Psychiatric Society during 2016-17 and conducted ANSIPS 2015 as an organizing secretary and president-elect in 2015-16. He is currently president-elect for Asian Federation for Psychiatric Association. He is in the presidential panel and planning committee of World Psychiatric Association. He has been editor and author for various journals in psychiatry and various social forums and societies. He participated and presented papers, case studies, being a speaker, panelist, chairperson, moderator, and orator in various national and international forums, nearly 150 conferences of psychiatry, geriatric psychiatry, adolescent psychiatry, social psychiatry, and private psychiatry, forensic psychiatry, and disease-focused deliberations like schizophrenia, bipolar disorders, Alzheimer, and dementia. He authored and contributed to many books and journals, also to the textbooks. His notable work is in the book Dementia, Thoughts, Themes, and Variations. He is continuously writing columns in English and Telugu magazines on mental health and social awareness, and actively conducting TV shows in Eenadu TV and Doordarshan Telugu for last 15 years and helping people psychologically disturbed through mental health education. He organized and functioned as a pioneer office bearer as organizing secretary in more than 12 national and international conferences. Here I want to highlight his commitment towards the recent psychiatric midterm CME organized by him in the month of March 2024. Unfortunately, he had a severe cardiac issues and undergone an angio, and he conducted the conference successfully without modifying the dates and attended the program and chaired session through online platform from his hospital room. Hats off to you, sir. Your action truly reflects your tagline, in service of Indian Psychiatric Society. Over to you, sir. We were delighted to hear from you on the topic Cholinergic Pharmacological Management, latest update on Alzheimer's.
Thank you, Rajamanikim, for those wonderful words. I don't know how much I deserve, but we are committed to understanding and learning. I'm still a student. And what probably you didn't add is I'm just finishing my PhD in dementia, Alzheimer's dementia. So having said this, happy Dasara to you. Just now it's gone, and happy Deepavali, which we are going to come in the next 8 days. So all of you, I'm happy that Helion has asked me to talk on one of the subject of my heart. As we get prepared, I think the way I would go, I have no financial disclosures to declare. May I have the next slide, please? The core topic which I'm going to cover today is what are the real pharmacological treatments in Alzheimer's. And towards the end, I bring with the greetings from Asha Hospital, where we are running uh, not only the dementia clinic, the old geriatric psychiatric clinic, we also have a 40-bed geriatric center in which we keep the house. So, with this background, may I now request for the next slide, please? Dementia are essentially two components. Most people think that it's only memory component for which the patients come. In fact, that's not the true. Uh, in a general psychiatric practice, 70 to 80% of dementia patients come to us predominantly for the behavioral and psychological components. And yes, there are memory components too. May I have the next slide, please? I would elaborate as you see. This is one of my patients' MRI, as you can see. And can I show? This is taken at the end of 2 years, but I followed this patient for the next year. Can I have the next slide, please? And what you find is the increase of the hippocampus atrophy, as you can see. The size of atrophy, as I can show you here, hopefully the black thing here, uh, as you can see very clearly, this is how, and you can see the majority of the cortical matter is almost getting atrophied. This is a patient who is suffering for after diagnosis is the 18th month MRI, and if you can see successfully, in fact, it has thinned up in the last 3 years. This is one of my old patients whom I am following for a long years. May I have the next slide, please? Now, I would start with a bit of a difficult statement. Our diagnosis of dementia is usually too late. The reason why I'm emphasizing is patients in that age group, and dementia starts anyway after 60, 65 years. So, forgetting is generally considered as an old age phenomena. Not only that, the family is not having great demands from him regarding the memory at that point of time, him or her, and they only start visiting either a neurologist or a psychiatrist. And I'm very sure, pretty sure that they come much more to us than the neurologist for the simple reason behavioral symptoms, which I'm going to show you in the next few slides, are the predominant reason why they come to us. May I have the next slide, please? Well, this is a fascinating projection of what is likely to happen. And this is, ladies and gentlemen, from our own country. In 2015, we had roughly, and you can see the blue graph and the orange graph, and this is a projected figures. Though we are somewhere around here, and growth in numbers of people of dementia in millions in both high income countries and low income countries, low and middle income countries, seems to be not so different. In fact, what you find here is, in fact, the high income group, as you can see, has more or less plateaued on, whereas you find that low and middle income, the dementia cases are actually going by leaps and bounds. And they started at 28, and 2020 they have reached 32.30. By 2025 you can see a phenomenal growth of more than 5 million, and you can see exponential growth by 2030, and so on and so on. So this is based on our own grape area population, but also as we have conquered infections, we are now left with the inflammatory and degenerative disorders. May I have the next slide, please? And this is yet another slide from our own country, from ARDSI in India in millions. Don't be surprised. In 2005, we had only 3.1 millions. And by 2020, we are almost doubling by 5.3. And 2025, we had 5.4. But you can see the phenomenal figures projected. And by 2035, we are going to be a large, almost 10 million population will be suffering. And this is really a underestimate according to most of the researchers in dementia. May I have the next slide, please? This probably, though my title was Alzheimer's, I thought dementia is an umbrella term, and dementia is an umbrella term used for any loss of memory with overthinking abilities and severe enough to interfere daily life. That's a very broad definition, of course. You have predominantly, and I'm going to show you in the next slide, of course, in our country, 70% of patients are Alzheimer's and vascular combined. And what are the areas which are normally affected? All the areas which are related to the executive function, emotional regulation, the dorsal anterior cingulate cortex, the medial prefrontal cortex, the medial prefrontal cortex, and the lateral prefrontal cortex, the most important areas, and of course, even the anterior cingulate gyrus with the ventral anterior cingulate cortex, which are all the connecting circuits of the both behavior and memory together. As you can see in the three, we have three kinds of things. We have a cognitive control network, which is shown in the picture towards the left. In the middle, you have the default mode, which most of us explicitly work, but the implicitly the ER is mostly the ventro-anterior cingulate cortex. What I'm trying to summarize is the brain globally might be affected, but some areas are much seriously affected. That's a message in any dementias, be it Alzheimer's, be it vascular, be it the subcortical or lacunar infarct related dementia, also be it the other kinds of dementias which are much less luckily for us. May I have the next slide, please? Having said that, what this is probably is the summarization which I told you. This is one of the recent publication in our country. What you find is dementias along with vascular dementia and Alzheimer's together would form roughly around 75% or more, whereas Lewy body is less than 5%. Lewy body with Alzheimer's can still be 6. So the other dementias together might actually minimize, whereas Alzheimer's with other disorders, which includes vascular dementia, Lewy body dementia, frontotemporal dementias, all, and luckily, I think we are not finding too much of an AIDS-related dementia. A very small component of alcohol dementias are also part of this other dementias together. So this, what is the take-home message? Yes, Alzheimer's is the key driving force of the dementia group, whereas all others add on to Alzheimer's. Incidentally, and may I have the next slide, please? If you really look at the etiology, we really don't know. As you can see in this picture, people's deteriorate, and this is one of the beautiful one which I borrowed from one of the World Congress. What you find is the same individual at various ages, how they face changes, body changes. But here, though it is pictorial, it actually shows the destruction of the facial faces, but most so the kind of a behavioral changes. Now, significantly, as I told you, attention deficits and memory and emotional symptoms start very early. Learning is definitely affected. Language, for example, they wanted to say pen, they would say something else. That can happen much more in the frontotemporal dementias. But independent of the behavioral symptoms, and a variety of behavioral symptoms can occur, but cognitive deficits progress depending on the type and depth of the lesion which that individual goes through. May I have the next slide, please? As you can see here, this is probably the one which I thought I would want to focus a little more. Actually, the disorder might start according to, especially those where there is a genetic component of Alzheimer's. And for that case, 20% of all Alzheimer's have some kind of a familial history. It is less than autosomal recessive, but it is definitely there. But having said that, the symptoms start somewhere around the age of 50s to 60s if you can really check at that point of time. And as you can see here, my focus would be is that the late treatment and uncertain outcomes is each Alzheimer's is independently different. And today, probably we are looking for dementia biomarkers, and dementia biomarkers, some of them are already getting emerged as a positive things. But today, talk is not regarding biomarkers, but sufficient for us that saliva mediated, blood mediated, neuroimaging mediated biomarkers are going to be the certain things in the near future. But what I want to focus is, as you can see, the top line, blue line is the normal aging. You can definitely see a deterioration, especially after 65 years. And as the age progresses, in fact, there's a dramatic drop, and that's what the graph shows. So mildly impaired might start somewhere around 60, 65, but by between 65 and 70 is the real drop. And as we progress, you get to see the lot more serious cases. May I have the next slide? Now, I just want to start my broad topic on anticholinergic. In fact, from the therapy point of view, we are in our country today, we can only talk about the cholinergic pathways and NMDA antagonist memantine. And these two actually, these two groups of molecules actually, rivastigmine, donepezil, galantamine, are within that acetylcholine esterase which remain. I'll also show you in the next slide all the history of the molecules, but at the same time, we are left with only these three molecules to rivastigmine, memantine, and donepezil. And I'm going to delve much more on how to start the treatment and how to go forward. May I have the next slide, please? Well, this is one of the area which I'm working, and what one of the area which I think is identify as I keep focusing mild cognitive impairment. So my general recommendation is we should get at least an MMSC every one of us after 60 years every year. That would be a kind individual, but the following complaints are the ones which I want everyone to remember. Initially, the individual struggles to find the right word, as I gave you examples. He is wanting meaning to say pen, but he would say something, something to, something to, something to. He will indicate by some kind of a visual. Again, forgetting recent conversations is one of the early symptom which we should catch. Most important, based on their own background education, there is a complete, slowly but complete deterioration of the executive functions within the brain, which includes all the complex tasks which they do. MCI, what is called mild cognitive impairment, can be amnesic or non-amnestic, but both can be recognized by, especially after 60 years, by proper testing methods. Conversions of MCI to Alzheimer's, roughly, though the figures might vary across the multiple studies, uh, it can deteriorate into dementia by 3 to 7 years. So there is a conversion rate of 10% every year, but again, that has been strongly, hotly debated. But having said that, what our goal is, both mild cognitive impairment and Alzheimer's need to be attended both for the sake of the patient and for the carers, which I'm going to cover. May I have the next slide, please? As I said, we can, please click it again. As you can say, the treatment part, the impaired memory, increased risk of developing dementia is 5 to 10%. And this 5 to 10% keeps changing as the years, as we progress rapidly. So, but the beauty here is roughly at least 30% recover immediately with our cholinergic treatment, the cholinergic drugs which we have. The we right now slowing the process and recovering some of the behavioral symptoms are very well established, but adding vitamins, especially folic acid, B12, and B6, and managing the diabetes, hypertension, because these are the ongoing modifying factors. And of late, we talk about cognitive stimulation by using some apps, by using some computer games, which we can actually delay the progression. This is evidence based at this point of time, especially for the MCI. May I have the next slide, please? Now, diagnosis of dementia, I think we need to develop strategies. One of the strategies I normally recommend is screen for memory loss or memory deficits. And what else we need to do? And this is probably a summary of the risk factors: diabetes, COPD, obesity, alcohol, and smoking are the five culprits. Just like in the cardiovascular and diabetes, these five risk factors actually are above 60. These are the high risk group which need to be evaluated. Of course, Down syndrome and learning disability are supposed to have a little higher, and patients with other neurodegenerative disease also have. Now I'll come to the basic molecules which are available at this point of time. And reversed, may I have the previous one, please? The next one, tacrine. Yeah. Now, this is the broad history of cholinergics, and galantamine also is broadly classified in this class. 1993, tacrine came, but one of the problem with tacrine which has to be withheld is one, the tolerance was not good, and it has to be given multiple times. The next in the line, both 1996, 97, we had one donepezil on one side and rivastigmine the other side, which have been approved by US FDA after multiple trials. And probably today, these are the two molecules which seem to have. Galantamine was introduced in 2001. Somehow it was not found to be very great. So in the end, we are left with two important molecules in our country, among the cholinergics, donepezil and rivastigmine, and among the NMDA, we actually have only one molecule, which is memantine. Rivastigmine, when compared to donepezil, is highly brain selective. It works both for acetylcholine esterase and beta esterase together, and galantamine acts only on acetylcholine esterase and alpha 7 nicotinic receptors very mildly. That might be the reason why galantamine did not really stand up to be a great molecule in the helping of the dementia patients. May I have the next slide, please? Now, rivastigmine is a choline esterase inhibitor, and one of the beauty of this molecule obviously is it works for evidence based, of course, mild to moderate and even severe. Right now, we have data. Now, the difference is if you give orally, there are likely to be more side effects in the early stage. Whereas if you change that into a route of transdermal patch to reduce the prevalence of side effects, this is well documented over the years. And in fact, the transdermal patch, which I'm going to cover a little brief, more detail, because I think not many companies in our country have this. And the one of the reason why I prefer is because in dementia, as the disease advances, patients have difficulty in taking tablets, both not only forgetting or even the carers have to give many a time. So this would be giving just a patch per day. That would be easy. May I have the next slide, please? Going further, the pharmacology, the psychopharmacology of it is it inhibits both acetylcholine enzyme and the beta choline esterase. Now, the selectivity here from the G1 isoform of acetylcholine that predominates in the certain areas of the brain is considered to be a differential molecule among the cholinesterase. And this, relatively, if you see, among the two molecules which we are used here, rivastigmine survived the other three. For example, tacrine lost the game very early, but right now we have both rivastigmine and donepezil, and there are some interesting differences between donepezil and rivastigmine. And rivastigmine came to our country a bit late, but it is now, I think it's coming, making a comeback again. May I have the next slide, please? And this is how it works. As you can see, presynaptic coenzyme converts the choline into acetylcholinesterase, and that passes the presynaptic to the postsynaptic. You have both muscarinic receptors and nicotinic receptors. And what this acetylcholinesterase, which metabolizes the acetylcholine, is blocked by these molecules, be it rivastigmine, be it donepezil, be it galantamine. They work just at the synaptic level, and this helps by preserving the choline, acetylcholine, for a much longer period. And acetylcholine actually is the predominant memory. But right now we know not only for the memory but also for the behavioral symptoms, a composite computer overplay of multiple systems between this acetylcholine and other neurotransmitters is an important game. And that's why each molecule has its own unique place. And we'll come to see a little bit of this data as we go further on the evidence based. May I have the next slide, please? This is how I would try to really show to you from a pharmacological point of view. As you can see here, the inhibition, I already told it occurs at the postsynaptic level, but the whether it changes the tau protein formation by the neurofibrillary triangles as told by Alois Alzheimer more than 120 years back. It also probably affects the mitochondrial dysfunction, which closely gets associated at the postsynaptic, thereby reducing the apoptosis. And the reduction of the apoptosis might reduce the amyloid. So, this is the pathway which it works. And here, for the interesting sake, I compared as you can see, the number one has donepezil, galantamine, rivastigmine. Number two is memantine, NMDA antagonist. The third one is the newest baby. There are one more baby, which, and interestingly, aducanumab, and the other, which I will go to show you in the last slide. These are the newest baby. These are unlike these molecules. They are likely to do something for amyloid, and I'll come to that little bit. But suffice for us to understand that choline esterase inhibitors are the molecules which are ruling roost right now in our country. We don't really have the third group of molecule as yet. And this third group molecule, the data is just emerging. It's only 4 years now, and it's too early to comment because though, and US FDA, interestingly, during the COVID time, has given what we call a active rapid approval based on a few studies only. So that is one of the criticism, and there are some pros and some negatives which we will come to know in the next 2 3 years. May I have the next slide, please? Now, rivastigmine, for example, I'm trying to show to you, it is not just the cholinesterase inhibitors, but it also acts on a calcium-dependent sodium channels passage. And this positive modulation actually helps the nerve to regenerate. And this has been shown in multiple animal experiments. So, rivastigmine acetylcholinesterase pathway, as you can see here, there are other multiple agonists which they are trying, but they couldn't really sustain very well. Rivastigmine probably seems to have probably come to stay with us with more than 25 years of life. In When I say 25 years of life, I'm saying it was introduced way back in 95 with us. May I have the next slide, please? The other thing which happens is, in comparison with donepezil, it also does, but it has a slightly different action from a uh, from a totally psychopharmacological point of view. The acetylcholinesterase action is there, but it acts through a slightly different pathway. The Is there any differential? And I'm going to show you the differential in some of the studies in the next few slides. May I have the next slide, please? So broadly, if you want to remember, choline esters are acetylcholine, methacholine, carbachol, and but unfortunately, if you give acetylcholine, it gets metabolized in the stomach itself. So we need some kind of a things. Anticholinesterase, among them, reversible anti cholinesterase cannot be used like physostigmine, neostigmine for the very short life they have. But rivastigmine among the carbamates is probably the one which has the longest time, along with donepezil and galantamine. Among this, in that order, rivastigmine and donepezil might be more or less neck to neck, but galantamine is a little behind. The acridine group of molecule tacrine did not survive. The other carbamates like carbaryl and propoxyphor did not really stand the test of clinical trials, so they are not available. They are one of the reason mainly is because they are irreversible. So it causes a very permanent kind of a things, and it didn't really pass the you can say US FDA standards of even the first level, second level approvals. May I have the next slide, please? One basic take home message about rivastigmine pharmacokinetics is bioavailability is quite great. Protein binding is 40%. Metabolism occurs in liver. So more often than not, most other conditions we can give without any problem. But the elimination half-life is 2 to 4 hours. So that is an issue, especially if you are giving as a tablet form. So we need to bypass this to give a long, prolonged release, or the one of the best ways to deliver by a dermatological patch in which the drug slowly released into the body and the PKs are maintained for more than 24 hours. In fact, it is 23 to 24 hours. There is a slight variation among depending on certain biological parameters, but roughly we can take it as a 1 day a patch is ideal. May I have the next slide, please? Now, as I talked, I was comparing these three because these are the three which is available at this point of time. Donepezil and rivastigmine. Memantine, of course, does have. You can see I'm ticking some of the things to show you the my own. I would say kind of emphasis. Certain side effects of donepezil are much higher, whereas Alzheimer's in moderate and mild and severe can be given, like in both the cases, like donepezil and all. Memantine can be given in moderate to severe. So the comparisons say, but they do have significant differences across the system. Of course, cost effectiveness is one more variable which all the three share more or less. Because remember, once the diagnosis, it's for lifetime. We have to give any of these molecules, and it is probably in our country we are using multiple drugs together to actually maximize the effect of uh, choline cholinergic system being activated through it, dopamine and norepinephrine and serotonergic system too. May I have the next slide, please? And high efficacy and less side effects has always been unique for rivastigmine. Cost effectiveness, initially it was used to be quite expensive, but right now, thanks to the you can say Indian innovation, we are able to deliver at a fairly affordable range, and especially the patch, which once we give it is kind of useful because, as I told you, most of our dementia patients do not take tablets, or they swallow and throw it out, and all these things that can be circumvented by giving the patch. And the gap is availability. The patch concept, for example, efficacy ensures definitely more than 24 hours, but as I put it very thing, at least for 24 hours it's there. So if you're delaying 1 day, 1 to 3 hours, the next day patch, still there will be some drug available and the efficacy continues. And as you can see in the picture, it's very simple. You can keep it on any part of the body. You can keep on the hand, you can keep on the back, you can keep on the thigh, depending on, or on the chest wall, and it hardly has any side effects. And I have been using it for the last so many months, and my patients and their carers are so happy because they don't need to give tablets more than 2 or 3 times for this cholinergic purpose. May I have the next slide, please? Now I'll show you the basic kind of evidence from the farm clinical trials point of view. This is one of the earliest trial, the SWAP trial, in which there was a 25-week trial in which 261 patients. Initially, the efficacy, along with the efficacy, they have tried to change from oral to the patch, especially those who are receiving donepezil to. So this is one which I thought I will show you because this is a comparison in a way from donepezil changing over to rivastigmine patch. Okay, may I have the next slide, please? And it's a randomized double blind. And as you can see very clearly, the graph is very clear. I think there's no confusion. Majority of patients receiving donepezil can be safely switched to rivastigmine without significant deterioration, neither in cognition, nor in behavior, nor in the global tolerability. So, apart from this, we have yet another trial. This is published in 2010 in Journal of Clinical Psychiatry. You know, Journal of Clinical Psychiatry is a very efficacious, very standard general. Then there is another trial in 2014. This is, of course, 6 months, double blind randomized placebo controlled multicentric trial in which the varieties here, rivastigmine capsules were compared with the patches. Because, and this is a huge study of 1195. And there are three publications from this study, and I'm quoting you just one study about this. May I have the next slide, please? And here you can see very clearly the patch which is available. There is further improvement of the Adcock trial in the top two lines, whereas the other two there is a deterioration, which is so favorable skin tolerability is one result which we found. Not only that, because probably it is maintaining a probably higher therapeutic than compared to the capsule. Here you found in these two groups a much definitely based from the baseline they improved. Of course, three groups improved, one deteriorated, the placebo. But the point here is you can see the difference between the skin patch and so the take home message obviously is probably patches are definitely more suitable. The title of the study, as you can see, is ideal, but it's not got anything to do with the result preposition. It has got to do with the acronym used in the trial. That is the dementia related study. That's what acronym. May I have the next slide, please? The yet another study is even much longer. This is yet another study, as you can see, almost 2,000 patients for 96 weeks. It's again a multi-centric, comparing efficacy, safety, and tolerability of higher dose of the patch. So this is, as you know, if US FDA has to approve, it has to go through all this pathway. So this is one pathway in which has clearly shown. And now I'll show you the slide in the next slide. May I have the next slide, please, of Optima results. And nothing different from the previous conclusion. The higher dose efficacy was they tested the pharmacokinetics also 13.3 milligrams one on a functional outcomes without compromising safety and tolerability. Incidentally, there are almost in all these three trials, there are no serious adverse events related to the drug, that is both the patch or the tablets, and nobody died because of the medicine. And most important, the tolerability was nobody dropped out because of the severe side effects. So this is the take-home message from the three important studies related to rivastigmine patches especially. May I have the next slide, please? Now, this concept, how to apply, how to start. Now, you convert the dose, you start with the lowest dose, you actually try for a month. Then, based on the requirement, there are three doses available. You slowly but surely hike up to a better tolerable once they tolerate better. When I say tolerate, there will be initially some cholinergic side effects, which includes diarrhea and nausea as the most common side effects. Nothing much more than that. Pain, abdominal cramps, some in a very small percentage they are false, but remember in this group of patients of dementia with a multiple etiologies, the falls can need not necessarily be due to the drug side effect. May I have the next slide, please? And the practical benefit, as I keep telling already two or three times I told, once a day application, and the caregiver who is available with the patient can just apply and go away. And we have not seen in my patients at least patients trying to remove the patch at any point of time, and it it seems to be part of their body like a bunion, inner bunion or something. Nobody actually notices that, and it has got nothing to do with the taking before food or after food, as you know, because it's a sustained availability all through the day. May I have the next slide, please? And practically, you start with the lowest dose and go to the and it has a three layer, as you can see in the in this photo. The backing polyester layer right on the top, followed by the drug adhesive layer in the middle, and protective liner. And this way, the drug is well protected and it releases very slowly but surely. May I have the next slide, please? How to use, I'm just showing those for those who have not used. Just remove the outer patch, take that patch, keep it at any part of the body, and I suggested both. I normally teach my family members that start with left, right, left, right, left, right, chest, left, right. So 1 week is over again, so that the family is generally concerned about if you keep it in same place, what will happen. Actually, nothing happens according to me, but you are giving a novelty to the caregiver. Keep it in different places, like they teach you for the insulin injections. The sticky side of the upper lower back, upper arm, the chest, these are the preferable ones, apart from the, and this is the parts I normally recommend. Definitely not on the abdomen, because at least in old age, they have a chance of scratching their abdomen and all as a habit and all. So I normally take care of left and right first, shoulders to downwards, back or front is okay. Chest also, back or front is okay. May I have the next slide, please? No part. Now I'll come to the second part of my presentation. Some of us will be questioning how to manage the behavioral and psychological symptoms of dementia. May I have the next slide, please? These are the more common symptoms which the patient comes. In fact, there are about 14. I just kept here the following. Restlessness and agitation is one of the most troublesome. Physical aggression also can occur. Screaming, agitation, wandering, sexual disinhibition, shadowing. This comes under the behavior. And from the emotional symptoms, depression, apathy, paranoid delusions. The patients keep complaining that they are taking away my money, they're taking away my property, they're taking my papers. So that would be the paranoid kind. So external behavior wise, these are the commonest things. May I have the next slide, please? As I said, anxiety, depression, delusions, and hallucinations form. And I can say this much. I've been working with dementia over the last almost 11 years now. Mm, as I told, I've been my PhD work is in the Alzheimer's. So the BPSD occurs in up to 90% of all dementia patients, all varieties, without any differentiation. So now the question now commonly asked is, do the cholinergics help? The data is very clear. All cholinergics help in reduction of all these symptoms. But nevertheless, we might have to use certain other medicines. There are definitely, from US FDA point of view, a kind of a signal saying be careful with antipsychotics. Why? Because there are increased number of falls. There are falls leading to fractures. There are severe neurological side effects and severe sedation. In fact, the patients with dementias, especially and Alzheimer's, they have a difficult sensitivity of the brain. So we need to be very careful. Nevertheless, from time to time, we use atypical antipsychotics to some, but with a very great caution and explaining. The other important behavioral things which we need to manage is physical contributory factors. Remember, I have seen in n number of cases in which patients have been having some memory, but they suddenly deteriorated because of a physical infection, a severe acute abdominal pain, or a severe constipation. Otherwise, many a times their activities of daily life gets affected. And not to forget, most of these geriatric patients are on multiple drugs, be it anti-diabetic, be it antihypertensive, be it lipid reducing, and a variety of host of cardiac medicines, nephrology medicines, respiratory medicines. So delirium is one of the important factor which can definitely occur in Alzheimer's and any dementias. So we need to manage that separately. And many a times delirium is part of the dementia. Sometimes they present with acute delirium, which can be due to any of these above causes. May I have the next slide, please? Now, as I answered already, the cholinergics work much better in Alzheimer's and vascular disease, but in Lewy body and Parkinson's, no, they do not work very well. But at the same time, that's where, for example, today, I think in our country, just now, last this week, we have the primavaserin, which is a molecule which can be used for Parkinson's related psychotic behavior. That's very young, hardly 3 days or 4 days in our country. But low dose risperidone or low dose Qutipin or a low dose olanzapine is my choices. When I say low dose, as I said, we need to use a lot of caution in match. And sometimes in our center, in Asha Hospital, we do deep RTMS and we are getting quite good results, especially for aggression, agitation, and severe psychosis. And yes, some of you might be interested to know that we have given ECTs in some patients, and there is some evidence for that. Now, I will show you a few, quickly run through the other studies, rivastigmine versus donepezil study. It's again a very large study, 2 years RCT, total number of patients almost 1,000, mm, uh, one half each in two groups. The dropouts were slightly more in donepezil group, uh, but the cognition wise and behavior wise, rivastigmine was better in the improving the activities of daily life. That is, intent to treat kind of LOCF following using that. And one of the interesting thing is in patients above 75, especially rivastigmine, is found to be slightly more efficacious. But again, remember these are clinical trials are very interesting and very difficult to perform. And this itself, doing 1,000 patients, and as you can see, this is published in one of the best journals, Current Medical Research, is a good article which some of you want. Here, the take-home message from my side is both rivastigmine and donepezil are good, but there you need to be very choosy for some, definitely based on the efficacy. May I have the next slide, please? And as I want to summarize for each one of you, in the early stage, I normally start with low dose. I go and nausea, vomiting, diarrhea, and abdominal pains are can occur in up to 20 to 30%. That is almost one third of our patients. But luckily, there is a tolerance for the gastrointestinal tract. And if you give by transdermal, one thing for sure is there is a bypassing of the gut, which leads to lesser and lesser common side effects like nausea, vomiting, and acidity. And that is my experience. Well, very few cases I started rivastigmine patch, but at this point of time, I would think both for Alzheimer's and Parkinson's plus dementia. I think this is one kind. Regarding, there are evidence in other dementias too, fairly good studies. So when I say dementias, that's why I broadly classified them as Alzheimer's with or without others, and the others actually are less than 10 to 15%. May I have the next slide, please? One of the most important is start with 4.6 milligrams per day, go for 4 weeks, then increase to 9.5 milligrams per day, go for 4 weeks, and from then onwards you can up titrate to another, yet another dose. In fact, you can use a combination also. For example, 13.3 you can add 4.6 patch, which would actually increase the dose if you want to increase. So up titrate based on your patient's requirement, but closely following with the caregivers how they are reacting. And dementia is a group which we need to see almost every month. And what the way I do is every 15 days I do a video consultation, which is one way of seeing and educating the patient and family. May I have the next slide, please? Now I would like to close my today's presentation because lest uh, I'm not complete in the pharmacotherapy, though I started only with cholinergics. This is the new class of molecule, what we very superficially term as disease modifying immunotherapy. I already told you about adenocanumab and lecanemab. Both these molecules, one was approved in 2019, one is approved in 2022. So, this, from a neuroimaging point of view, removes the abnormal beta amyloid and also targets the beta amyloid, a toxic protein that's one of the cause for the Alzheimer's. But as I said, this is very young babies. Uh, there are hardly three studies which have been published for both each, three each for both these studies. And with the first two studies itself, US FDA gave a what fast track approval, but it's I think these two molecules have to be followed. May I have the next slide, please? These are not currently available in our country. So as of January 5, 2022, there are almost 143 agents at various stages of trial. In fact, the next week I am this 22nd, I'm having a meeting of BML molecule, which I'm going to do. I'm a lead investigator in this country. Uh, like that, there are lot of molecules which are likely to come. Ladies and gentlemen, the symptomology improvement of behavioral symptoms and cognitive improvement is our goal, and also giving a kind of a support to our patient's family. May I have the next slide, please? Now, when I say this, I normally close my lecture on dementia with these two important things. Remember, being with the family, targeting the carers is the most important, because carers are the maximum sufferers, and we actually spend. I run twice a month carers meeting in our hospital, calling all the carers. Usually, a huge 30 to 40 carers will come and join. They actually share between themselves simple tips of how to improve the quality of their patients, and also sharing, because it's a shock to the family members that previously a very brilliant people, nice people have now deteriorated in behaviors. So it is important that we need to conduct these care meetings, both mostly for carers, but also I also include the dementia persons as well. So non pharmacological interventions, and I also want to add quickly, uh, deep RTMS, which we are using, seems to be one of the options right now. But let us wait that we might get much better things in that area. May I have the next slide, please? So this is our group of our patients. Uh, what we do in our hospital. Activity center, we have a day center in our Asha hospital where patients come. There are trained people who actually work with the families of these people, and sometimes as a group, sometimes as one person. We, as you can see on the top here, we are teaching that gentleman to make some words spellings, and each here you can see the visual activity. Now the third one, as you can see, is a reminiscence therapy using old photos. Ask the patient to build up the memories of that time. So these are all the things which we have to do along with the medicines. May I have the next slide, please? Having said all these things, I would be very thankful. First of all, let us thank the company who has kindly asked me to share with you my feelings. I would like to, if there are any questions, I would like you to respond in the chats. If you can post it in the chat, I would answer. I think Srinivasan Balasubramanian has asked, Namaste, sir. Adverse effects, local and systemic, of this molecule. As I briefly covered in my presentation, I have around at least 60 patients right now in the last 3 months, who are going through this. Uh, Based on this, one of the things they found is previously they were getting lot of those who had lot of gastric side effects. They actually are not found at all with this patch, and hardly anyone discontinued. In fact, the whole family is happy because, one, very ease of admission, just keeping a sticky plaster on the body. I only educate them how to go about, and I think each one of you can do that. The I don't really have a long-term experience, so maybe my experience is limited. But uh, common sense, practical common sense tells us that rivastigmine, once it's tolerated, it's a usually donepezil, memantine, and rivastigmine among the molecules, which is probably the largest used molecules in our country, seems to have a good tolerance to the side effects as we keep using. And long-term effects, there are no cardiac, there are no renal, there are no probably metabolic. So this I'm sure about it. Of course, we have to manage the systemic disorders which the patients already have, but these drugs do not cause. Unlike, for example, olanzapine, which can induce diabetes, etc. Any other questions I would request you to put? I'm sorry I didn't inform right in the beginning, but or I would ask
There is one
Rajmanikim to
query.
collect the questions. We will definitely send to you as soon as I get the answer your questions.
Yeah, one more question, sir, from Dr. Deepak Kumar Sharma.
Yeah.
What are the adverse effects, local and systemic, of this molecule?
Yeah.
Rivastigmine
I think I did just started, but local by this patch, there is no rejection. No patient in my 30 patients, I can talk about the experience who are just following for almost, you can say 90 months now. I mean, 90 patient months. They're good. They're good. Now, adverse effects when compared to the tablets, definitely both nausea, diarrhea are hardly there. In fact, when I switched over from donepezil to rivastigmine patch, in a few cases initially moderate and severe, one of the reason why because the patients were not swallowing the tablets, the family became quite happy within a month time. So, take home message is side effects wise, patch is slightly definitely different from cap. I have not used rivastigmine. I used the initial when Johnson came. I used for a I have used Tacrine, I have used Rivastigmine. At the time, we used to give 3 or 4 times. One of the advantage of this patch is giving only 1 time per day. At that time, we used to give 3 times per day because half lifetime and all. I used to titrate it by morning 7 o'clock, afternoon 11 o'clock, evening 4 o'clock. Considering that in the night they don't need it because that used to last for about 16 to 17 hours. That kind. But patch works for 24 hours, so that is good. Systemic side effects, as I already told, encountered nothing worsened over the period. So I would just, I think I might wait for another 6 months. If Radhamanikam wants me, I will again talk to you on this, collecting more and more patients.
We really love to have another session also with you, sir. If there is a query from the group, that also we will address the next time. And with the latest advancement, we will be definitely discussing, sir. And it is a very thoughtful and very big thing you have concised and given us in this stipulated time of 55 minutes, sir. Thank you so much. You have shared your experience, and on behalf of Hetero, for your valuable time, you prepared everything and kept and given us as a juice of it, of your experience of 40 years and your knowledge on this particular special area. Thank you so much with a deep gratitude to you, sir.
Thank you, Raj. Thank you, Raj. And I would ask you to reach out to them, all the people, Devendra
Yes,
and the
sir.
team, that anyone has any questions, you can collect and send me by mail or through you person. I'll try to reply to the best of my knowledge.